Welcome, everybody, to the 2019 E. Stanley Crawford Critical Issues Forum, entitled Why Good Outcomes Are No Longer Good Enough. I want to give you a little bit of a history of the Crawford Issues Forum, and something I actually wasn't all that aware of myself until I researched this. In a February 19, 1988 letter to the members of the Society for Vascular Surgery, then restricted to just 250 active members, E. Stanley Crawford wrote, "Thanks to our predecessors, vascular surgery has become an exciting field of medicine. It's now incumbent upon us to maintain and even improve it. In my judgment, this cannot be done by maintaining the status quo because many of the socioeconomic, legislative, and legal challenges which are occurring in our society, the scientific demands imposed by the academic community, and the continued introduction of a broad spectrum of technology. The challenges which for these factors are posing to medicine in general and vascular surgery in particular are critical." It really sounds very much like the exact landscape we find ourselves in today. And poignant to President Macaroon's concerns about vascular surgical manpower, he pondered who would want to go into vascular surgery. Got a lot of sequence. He went on to lament that traditional operations may be going out of style, replaced by advances in technology that have led to development of optional and unproven methods of treatment that may prevail because they are simpler, safer, and cheaper than traditional methods. And again, poignant to Dr. Macaroon's concerns about the vascular surgical manpower issue, he pondered who would want to go into vascular surgery today with the uncertainties of tomorrow and how those already committed can remain dominant. Well, the only thing that's certain in life is that there will be change, and vascular surgery has certainly seen its share of it, certainly over the course of my career. But out of this deeply held concern for the future of our specialty was born the E. Stanley Crawford Critical Issues Forum. Initially, an entire day devoted to tacked on to the SVS meeting focused on addressing the challenges of vascular surgery. Over the years, the forum has addressed the need to incorporate endovascular training into our training paradigm, more than once, I might add, the manpower shortage in vascular surgery, healthcare reform, conflict of interest in medicine, and many other issues of critical importance to the survival and leadership of our specialty. At this year's Critical Issues Forum, we're going to take another look at what many view as the most critical issue healthcare faces today, and that is the appropriateness of care that is delivered and why good outcomes are no longer good enough. I have nothing to disclose in conflicts. Through the 1990s and into the early 2000s, in the Northern California city of Redding, population 80,000, a non-board certified cardiologist, Shay Moon, and a Stanford-trained cardiac surgeon, Fidel Velasquez, led their respective divisions in the cardiac program at Redding Medical Center, a 238-bed hospital. The program was highly marketed, quite successfully so, and renowned for its outcomes with an enviable coronary bypass mortality of only 2% and health grades ratings consistently amongst the best in the United States. Dr. Moon routinely performed 2,000 invasive cardiology procedures annually. That's 38 a week, or slightly less than 8 cases every workday of the year. The cardiac program accounted for 40% of the hospital's revenues, with nearly 1,000 coronary bypass cases being performed in 2002. At the time the FBI raided all related facilities on October 30th, 2002, the rate of cardiac procedures and surgeries being performed was 4 to 5 times the expected rate for a hospital of its size and the population it served. In the financial quarter preceding the FBI raid, the 238-bed Redding Medical Center's pre-tax net income was $33 million, which annualizes to $132 million. For comparison, 900-bed Washington Hospital Center reported $14 million of annual pre-tax net income for 2004, approximately 1/10 of the Redding Medical Centers, despite being over 3 times larger. The resultant FBI investigation documented greater than 600 unnecessary coronary interventions or surgeries. had been performed over the prior decade, and many of these resulted in death or disability. All this despite repeated medical staff warnings to hospital administration beginning 6 years prior and 7 physician complaints to the California Medical Board in the years prior to the FBI raid. And ironically, Reading Medical Center had received a 3-year JCAHO recertification just 3 months prior to the FBI raid. And while criminal charges were never brought, perhaps because of prosecutorial incompetence, Tenet Healthcare and the doctors ultimately paid over $450 million in settlements over these issues. So let's ponder for a moment what might have been going on. I can only think of 3 reasons why you would have unindicated treatment: incorrect evaluation, incorrect treatment plan, or improper motivation. Now, the first 2 of these are things that we can usually address with education, but sadly, the latter can only be controlled through regulation, for which we have only our wayward colleagues to blame. I won't ask for a show of hands, but ask yourself if you believe that unindicated diagnostic or therapeutic procedures are uncommon. And in fact, furthermore, ask yourselves if you truly believe that it's only the other guys that are doing the unnecessary procedures. So for vascular surgery, it all seems to have started with the endovascular revolution, prior to which a failed bypass graft was actually considered a failure. Contrast this to today, where failed endovascular interventions and subsequent reinterventions are routine. But that may only be part of the explanation for the disproportionate rise in endovascular interventions versus decline in bypass grafting seen over the past decade. Clearly, the opportunity to perform endovascular interventions in a setting removed from typical hospital oversight, even though we know that didn't work in Reading, is a temptation to push boundaries that many cannot resist. This can be especially compounded if one is also an investor in such a facility. Quite candidly, I would say that we're typically taken at our word with patients and insurers that what we do is indicated and in the patient's best interest, but unfortunately we know that's not always the case. The Reading Medical Center tragedy resulted in a report to Congress delivered in 2008, 6 years after the cardiac program at Reading Medical Center was shut down, and typically showed that the hospital processes simply did not work. Why didn't they work? Quite frankly, because the hospital shielded its cash cow doctors. Can I get those slides back up? The hospital shielded their cash cow doctors, basically. And in fact, the CEO at the time was quoted as saying that cardiac services had no complications that required peer review. And he went on to say even further that their cardiac service was so advanced that their medical staff would not have had the knowledge or expertise to review these cases. So we now know that when hospital processes don't work, when the hospital's in on the gig, which to some degree or another we find in other hospitals across America today. So unfortunately, like it or not, the reality is that some degree of regulation is inevitable, and if we don't step up and regulate ourselves, there are plenty of other people willing to do it for us. I would say that we let the bureaucrats develop our EHRs, and you know how that worked out, so I think it's incumbent upon us to be able to regulate ourselves. So it's to assist SVS members in navigating the changing landscape of quality, the SVS has assembled a prestigious panel here today who will be taking us first through the government perspective on appropriateness, and then on through 3 key SVS programs that can help our members deliver the right care at the right time and in the right place. So to open this up, I'm happy to introduce Arlene Seed from the Medical Director of the Quality Assurance for the Pennsylvania Department of Health. Across America today, vascular care is being delivered and rendered in by more specialties and in more sites of service than ever before, presenting new and increasing challenges for those whose jobs are to ensure appropriate quality medical care to the public. Dr. Seed is here today to enlighten us about these challenges and how professional societies and government agencies can work together to achieve mutually beneficial goals. Dr. Seed, would you please come to the podium?
Good morning, and thank you so much for inviting me to speak. I'm just going to, okay. My name is Dr. Arlene Seed. I'm the Medical Director of Quality Assurance at the Pennsylvania Department of Health, but I have a couple disclosures. I've got no financial disclosures or conflict of interest. However, the views expressed here are my personal opinion and do not represent the position of the Department of Health. So I'm going to take you through some background, some specific issues related to vascular surgery, factors that impact government rulemaking, and then how you as an individual or society can engage in that. So first of all, I'll tell you about the lens as a regulator. Regulations are the floor, not the ceiling, and should not necessarily be about achieving. At best, regulators should keep in the outliers. However, in the current trend, as we've just heard, more procedures are being moved from the inpatient setting to the outpatient setting. And why is that? Because they're more cost effective. In a world where we're being told that medical care in general is too costly, we are looking for ways to make cost of care cheaper and more economic. So the way we regulate is through the Centers for Medicare and Medicaid and Medicare Services, CMS. But this is primarily a payment system, so we regulate through a payment. As you can see by the graph, there's almost no place in the United States that doesn't have some kind of get paid by the government. But federal standards only apply for procedures that are paid for by CMS, unless your state says otherwise, and we'll get to that. Private insurance have different rules, so as long as you can get someone to pay for your procedures, the federal standards apply only for only for facilities that take federal dollars. Payment does not equal safety. While they're not necessarily going to pay for a procedure that is blatantly unsafe, the primary goal is to decrease the cost of services because they are primarily a payment service. Now, and partly why is that? Because healthcare regulations are still primarily a state issue. The constitutions, the framers said the right to regulate healthcare belongs to the states, thus states vary widely. Ambulatory care surgery centers' definitions differ state by state. In Pennsylvania, we have a three-tiered system, Class A, Class B, and Class C. I only know one other state that has that exact classification for their ambulatory surgical facilities. Licensing requires from whether or not CMS will license you, and so they have no regulations for their ambulatory care centers, to ones that have specific ones, like my state. And in addition to your own facility, there are certificates that are certificate of need. So it's not only what you do in your own facility, but it is what everybody else in your neighborhood, how many other people are doing the same procedures or that you want to do. And then if an issue, and this is kind of what he alerted to, causes enough public ire, even in states that have no regulations, they can develop special regulations for particular procedures. Cardiac cath is an example of that, where some states that have no regulations for any other procedures have specific procedures for that. So some of the concerns he echoed are the trends in ambulatory surgeries in care centers in general. And these are kind of some of the cases. There was a 2017 report by the Kaiser Foundation and I believe USA Today that talked about excess deaths in ambulatory care centers. The understanding that you can't just take what you do as an inpatient and move that to an outpatient setting, and the actual safety net that needs to be there is not standardized and not always clear. Hence, even though there's a lot of promise, and by the way, we in government may not even divide endovascular surgeries kind of the way the specialists do. It is combined with us with maintenance for dialysis. and not just peripheral vascular. So the classifications might be a little different. But there are large studies that say it could be of value and could be safe. However, there are also issues. As he talked about, there is bad actors, higher reimbursement, bad excess procedures. So conclusion is we have more questions than answers because we're just at the beginning of this, which actually is kind of a good thing. So what I'm going to talk about now is the kind of factors that impact how government thinks about making decisions about how we might regulate procedures. Well, of course, we're concerned about safety, and we do look at the literature, but by and large, for most of that comes to us, it's new and cutting edge. There's not a lot of studies when I started looking at this in Pennsylvania on outpatient work. There's public perception. If the public perceives that either something is safe or is too dangerous, it doesn't really matter what the literature says. So public perception is a huge, huge gauge. And then there's the risk-benefit ratio versus cost. Just like the federal government, governments in general are looking to reduce the cost of health care. So cost is a huge driver. So let's look at driving forces. There are external driving forces in where people come and want something, like when CMS took a lot of those peripheral vascular, having moved them to doctors' offices, decided that they'd vetted them enough in doctors' offices and enough patients, and moved what didn't cause issues onto the ambulatory surgical facility list. As far as I know, that's the first time they've ever done that. And when they did that, there was a huge amount of people who came and said, we now want to do these procedures. In some states, that was prohibited. That created an urgency. And when you have urgency, there's a timetable that it needs to be done as fast as possible. And one of the difficulties with that is that you may not always have the time to do the kind of thorough work that needs to be done. I'm just telling you that kind of on the side here. They'll try. There are internal drivers, like Pennsylvania has probably the safest, largest patient statewide reporting system for hospitals in the country. So if we see something, we want to address it. That usually the timetable on that is a little slower. So expertise, and that's where you guys come in. That can be kind of hard. Often in a health department, especially for your surveys, there's no in-house expertise. Medical directors like me, and I'm not a vascular surgeon and never hope to be one, sorry guys, are rare. So that means that the next person you have may not have any training in or healthcare expertise. Their training comes kind of on the job. For CMS certifiers, they can be either nurses, social workers, or dietitians. They may be your most trained staff. Their manager and the people who make policy may not necessarily have a good health background, and especially not the clinical knowledge that you would expect when you talk to a clinical colleague, or even someone who's outside of your specialty but still has that medical background and training. So you can get it from organized medicine, like your trade society, like the specialty society, the Society for Vascular Surgery, or sometimes, or maybe in collaboration, you can use your state medical society. Certification. We like certification because it's clean and it's easy, and it's usually done, hopefully, with the input of true experts in the field. And then, of course, there are leaders in the field. But for vascular surgery, that was really hard to find because for endovascular procedures, there's the vascular surgeons who do them, there's the interventional radiologists that do them, there's the interventional cardiologists that do them, there's in our definition, the interventional nephrologists that do them, and a host of other specialists who don't, so there was no set person. Like I had experience with, say, orthopedic surgery. When you do a knee surgery, I know where I'm going to orthopedics. But for vascular surgery, it was much more complicated. So there are types of government. There are statutes, regulations, and guidelines. Statutes are what the legislator does. Regulations are what the department uses to enforce them, and they usually go through some type of public vetting. And then there are guidelines. Guidelines are what the departments create to fill in the gaps. They tend to be the most flexible. There's a practical considerations. We talked about the fact that you can't do anything that costs too much, and you can't do anything that is too complicated and requires judgment. It has to be pretty clean and cut, and that's why we like certification. You're either certified or you're not. You have that piece of paper or you don't. So what can you do? Well, I would recommend for each of you that you know the statutes, regulations, and guidelines of your state. I can't tell you how many times we have people who come to us who complain about something that we may not even regulate. It belongs someplace else. Know the levels, as we talked about, whether it's a statute, because that can only be changed by the legislature. Your state, local government will not be able to change that through the department. Regulations, there might be more flexibility, but as those are vetted, it's much more difficult, but it's more possible. It may take time because it will have to go through a vetting process. Guidelines are probably the easiest because they fill in those gaps. Also, though, they also hold less power than the others. But I would, of course, consult a lawyer for this is not legal advice, but just a little bit of know-how. So find the person who is looking for expertise and engage that person. There's somebody, usually, who wants more information but doesn't know where to look. In fact, for me, it was rather difficult to find the specialist who did endovascular surgery because there's so many of them, and to be able to find the expertise to do that. So it helps if the societies kind of reach out a little bit. Work through your professional society. And I say that because though we get complaints about quality from individual physicians, we usually look at that individual facility. If you're looking for a larger policy issue, having more voices with expertise is very, very helpful and has much more impact. So if you're in a specialty field or in a growing area, it is never too late to start. So find out who your people are. Even if it isn't sitting there right now as a hot button issue, it certainly is in a growing area. And you can engage the person who does your regulations and tell them what your issues are. So they keep you in mind when it does become more of a hot issue, or it might drive, as we talked about internal drivers, that internal force. And last of all, remember that administrations change. So, which means that if you've done a beautiful presentation for one administration, even if it is of the same political party, you will have to do it again for the next person that's there. Because when administrations change, the leadership in government changes and the focus changes. So with that, I wanted to conclude my talk as I've talked a little bit about backgrounds, a little bit about the issues specific to endovascular surgery as they relate to government, and the factors that involve and how you and the society can engage to be able to ensure that the procedures that you do are regulated in a fair and safe manner. Thank you.
The SVS often uses past presidents to take on large jobs. And I'd like to introduce Dr. Tony Sadawi to talk to us about one such job that he has taken on, working on a verification program in vascular surgery for vascular service lines, inpatient and outpatient, to help address some of these questions and concerns that Dr. Seed was just referring to. Tony?
Thank you very much, Kim, and thank you also you and Dr. Seed for basically introducing my talk. I think this is very important. As you all know, surgery always on the mind of people, whether it's safe enough. And as you see here, it's also in delay press, in addition to the concern about quality of surgery and obviously surgical subspecialties, including ours, open and endovascular, there's a concern about that concern just mushroomed, and the Institute of Medicine finally put together what they felt the characteristics of quality care, which is safe, effective, patient-centered, timely, efficient, and equitable. In addition to that, also the concern about cost. And, you know, you see always all kind of slides about how much medicine costs, but 44 states currently spend more time on Medicaid than K-12 education. 44 of 50 states. The amount of money spent on an annual basis in the United States to take care of our population is huge. As you see here, employers will spend $2 trillion on health coverage by 2040. So when you add these two issues, quality and spending, this is why, no wonder why, the politicians wanted to change the way we take care of people. So that's what happened a little bit in the Accountable Care Act in 2010, where a lot of people think about it that it's an insurance reform. Basically, access to care. We're going to insure more people in the United States that are not insured now. But actually, in addition to being insurance reform, it's also payment reform, which came up with 11 different payment models, ACOs and bundles, and delivery system redesign, which included being paid for performance and quality. But actually, let's not fool ourselves. Basically, the idea is to reduce cost and increase efficiency, and thinking that will pay for increased access or the increase in insurance. The issue with this law is that was passed along party line, as you know, and now we hear still a lot of politicians that want to repeal it. Now, repealing the SGR, which was used to pay physician, that actually passed by bipartisan vote, and instituted a value-based purchasing program that was replaced basically by a similar, like merit-based incentive payment system, or MIPS, that, as you know now in your organization, physicians, if you do certain things, you get an update on your payment, and that's going to lead down the line to alternative payment models, which are going to be more complex. And this was passed again with bipartisan vote. But from all that stuff, the summary of it is that physicians are going to be paid differently. We're not going to be paid anymore for fee-for-service, and we're going to end up being paid for partial capitation and shared saving like the ACOs, or full capitations, which has now basically variable penetrations in variable market. Washington, D.C., for example, because we rely a lot on federal government workers, and they do have third-party insurance, papers for service in Washington, D.C. is still pretty high. But you go to other areas in other states in the country, that's changing quite a bit. So basically, though, what's happening is instead of being paid for volume, we're going to be paid for value. And as you know, value includes quality and cost. So this is what's been happening. If you look at it from a surgeon's perspective, we have now, if you go all the way down here to this square, surgical specialty, we already have surgical specialties being paid by bundles. If you think about the cataract bundle, by the total joint bundle, maternity care bundles, all that is bundling, and it's marching on little by little. And what's happening with physician compensation is moving from a guaranteed compensation model, even for employed physicians, into increasingly variable compensation, which include basically a guaranteed smaller base salary, but productivity incentive and quality incentive, and now other component coming down the line. But what defines quality and value? And if we don't, someone else is going to do it for us. And as you heard from Dr. Seed, governmental agencies, state health agencies, insurance companies, corporations, patient advocacy groups, interest groups are all ready to jump in and do it for us. But we need to take the initiative. We need to be able to define value and quality. And what I mean by we is us, like organizations that represent subspecialties like the SVS. So the SVS started thinking about putting together a quality program that could be tested and that could be taken basically to the field to be used to certify different centers. So this is not new. We've been thinking about it for many, many years. People in the leadership of this organization, prior president Enrico Asher, Michelle Macaroon, Clem Darling, Kim Hodgson, others. We've been thinking about this for many, many years. I remember 15, 20 years ago, we got together in Washington, D.C. in Georgetown, and we tried to put together a program to certify vascular centers. It didn't work. But American College of Surgeons actually has made a lot of advancement in that. And as you know, the cancer centers certification, the COC of the college, has been in existence since the 1920s, 1930s, the trauma center since 1974, and so on and so forth. So the SVS started thinking to work together with the college to come up with such a program. The college can offer the infrastructure and experience in establishing such programs, and they really like to do that. And also, they may help in putting such a program in operation if the SVS chooses to. Obviously, the SVS, we can offer the knowledge of vascular disease and its management, the political will to improve quality of vascular care, the long-term commitment to vascular surgery, its members and patients, and also, most importantly, we do have VQI, because most of these programs for the college, they had to come up with a registry, credible registry to use. And from the very beginning, I basically discussed this with the executive director of the college, Dr. David Hoyt, that we have the VQI and society would like to use that, and he agreed from the very beginning. So how to put these programs together? The college's got a system there, and the system relies on 4 areas. You set standards, you build the right infrastructure based on standard, and you use the right data to collect data, and then you verify the program with outside experts, which in our case are vascular surgeons. So these are the 4 criteria or 4 underpinnings or principles, guiding principle, how to put together a continuous quality improvement program. And as I said, you see what happened with trauma. They're working now on the 7th revision of the trauma certification program, and that's a program that actually showed to decrease mortality over years. Also, there's the COC program, Committee on Cancer, the bariatric surgery program, again, and most recently they came up with the standardized surgical care for children, which received a lot of lay press mention, and with that they started looking at verifying pediatric surgery programs. So these are in red, all the programs that already exist, and here in the column in white lettering are the programs that are being worked on now currently. And ours is the vascular program, which actually we've been working on for almost a year now. This is the group that's working on it, what we call the standard committee. And basically on that standard committee, what we did is we brought in all the leaders of different guidelines that the society put together and published, and we asked them to serve on this committee in addition to leadership from the society. SVS staff covered this, and the ACS staff, as you see here, and this is the group that is working now on this program. And this is how we did it. We got together 6, 7, 8 times now in the area of O'Hare Airport, easy access from east and west and south, and we started this process. The first thing we did, we got together and put together a grid about what every area of operation, whether it's aneurysm, lower extremity, carotid, what you need for an infrastructure in human resources, space, equipment, other services. Based on the grids, we are now finalizing the standards, which we started with 93 standards, and we cut them down to 42 standards. And we just met 2 Fridays ago in the area of O'Hare Airport to basically put more granularity around them. And we organize the standards along the 9 areas that represent various components of care. Here they are: a CEO and the organization leadership, commitment, program governance and scope, facilities that are available in a granular way, services and personnel, patient care, data, quality improvement, research and clinical trials, and education and community outreach. So these are the components now that all these programs are built on. So if you go and you see, for example, the institutional administrative commitment, we have 1 standard. If you go to program scope and governance, we have 2 standards, one related to the definition and scope of the vascular program, and the second is related to the program leadership. And now we're putting together the infrastructure requirements for complexity levels, so because we put this program in different complexity levels in OBL. And this is what we are collecting related to a program of what you need to put a program together. So we have now the standards. I'm going to show you the grid for complexity. We're trying to put now together the questionnaire that's sent to the program before the visit. And the plan is to visit between 6 to 8 to 10 programs from different complexity levels to test our standards. That's the beta testing period. Once we do that, then we will revise all the standards depending on what we see in the field, because we don't want this program to be onerous. We want it to be a program that can actually be used at different level of complexity, and whether inpatient and outpatient. So this is basically the complexity grid. So the way we came up with it is we basically have 3 levels. We have the highest complexity inpatient, we have moderate complexity inpatient, and then we have in the blue, as you see here, which is a moderate to low complexity outpatient. And that could be either ASC, as we heard, or OBL. Right? Now, we don't want to call them high complexity and low complexity, because we don't want to disenfranchise programs that are smaller programs. So we came up for the time being with this. We have SVS Comprehensive Inpatient Vascular Center, which is the yellow, but under that you could do all other lower complexity procedures in your centers if you're certified for that. And then we have the SVS Verified Inpatient Vascular Centers, and you could do inpatient, the green, or the blue. And then you have the SVS Verified Outpatient Vascular Center, where you could do the blue. So if you're certified or verified for a certain level, you could do all the stuff you could do below that. And for every one of these, we came up what are the infrastructure requirements. And I didn't put this for you to read it. I just want to show you the granularity by which we are putting now the infrastructure requirement for different centers in order to be able to be compliant if they want to be certified. Now, you might ask the question, well, we have vascular labs already certified. Well, everything that's already there is a process for their certification currently. Is going to be a check mark. So if you are IAC approved for vascular, non-invasive vascular lab, all what you have to do is check that box. Now, the good thing that we have clinical practice guidelines. You're going to hear about that in here. And that's became very handy for us as working on this program. Putting the program in operation, Most likely we'll work with ACS, possibility with IAC for the outpatient, but so what's the overarching principle for this? This is a program under the auspices of the SVS and the ACS to drive quality and value by helping the clinical team leader to leverage the infrastructure necessary in the institution, whether inpatient or outpatient, to perform various vascular procedures in an environment that is safe and conducive to excellent patient outcomes and experience. Thank you very much for your attention.
Thank you very much, Tony. As you heard in my introduction and in my talk earlier about paclitaxel, we think that the SVS PSO, the registry of which is our VQI, is going to play a huge role in moving forward in these endeavors. And we've asked Fred Weaver, chair of the PSO, to talk to us about just that. Fred?
Thank you, Kim. It's my pleasure to talk about the SVS VQI and how it can improve your practice, and specifically focus on the concept of CAPI. I have no disclosures except I'm a big fan of the VQI, and I hope all of you will consider being part of the Vascular Quality Initiative. Just a little bit of background. We continue to increase the number of centers in the Vascular Quality Initiative. We, for some time, have thought this is going to level off, but actually it continues to increase. And as of today, this slide's a little dated, as of today we have 571 VQI centers located in the United States as distributed here. Canada, we also have one in Singapore. It's based on 12 procedural registries listed here. We also have 3 in the works. An ultrasound registry in cohort with the Society for Vascular Ultrasound. The venous stent registry is going to roll out this quarter. And we also have a vascular medicine registry, and we are collaborating with the American Heart Association on that. And that also is planned to roll out in the latter half of this year. And VQI total procedure volume also continues to increase. We passed a 500,000 mark last year. We're currently enrolling about 100,000 patients per year. So we should, 100,000 cases per year. So we're going to hit the 1 million mark within the next 3 to 4 years. There's also 18 regional quality groups, as you know, distributed throughout the United States that meet twice a year to review their regional data and benchmark it versus the national data as well as their local members. Membership is interesting. There's about a even distribution between community, academic, and teaching affiliate hospitals, but one thing that's not commonly understood is that the vascular surgeons make up not the majority of members of the VQI. There's actually a 30% representation of radiology and cardiology as well. So it's truly a multidisciplinary quality database. So what gets measured gets managed, and what we're talking about today is managing the quality of vascular care, both improving it, but also the appropriateness of it. And the VQI is based on a quality improvement Donabedian model, which looks at structure, process, and outcomes. You assess the quality by comparing common and uniform procedures across centers and providers. Then you use variation in process and outcome to determine best practice. You identify best practices by centers that are performing and have the best outcomes. Then you make recommendations based on those practices, and then you benchmark those best practices for others to compare their own results with and improve their outcomes. So this has created a toolbox for quality and safety in vascular care, and this is just a list of the many things that the Vascular Quality Initiative does. There's a regional study group with the biannual reports, but there's also robust peer review research with 186 peer-reviewed articles using VQI data published to date. Device evaluation and surveillance, we talked about it in the morning session. is going to be increasingly important using VQI data. The paclitaxel issue is an excellent example about the importance of VQI going forward and looking at devices and surveillance for device issues. CMS coverage decisions have also used VQI data. The TCAR is an excellent example. We also heard about that this morning, how the VQI is being used to expand the options for care. Guideline compliance, which I will discuss a little bit, and Dr. Kreis will elaborate on more directly. But I'd like to focus on the Center Opportunity Profile for Improvement reports, which have been ongoing in our proposed Center Appropriateness Improvement Report. So the Center Opportunity Profile for Improvement Report takes the place of having to identify an adverse outcome for which many VQI centers need improvement. You need a physician champion, primary PI, who works with a statistician to model that outcome and provide a statistical model. A risk model is developed that identifies significant factors associated with the adverse outcome. And the statistical program is then created that will generate a customized report for each center and that is available and shared on the VQI website in the Share File tab. The importance of the copy report is it not only identifies the adverse outcome, but informs the center about how they can actually lower that outcome occurrence. These are the copy reports that have been produced so far. The first infrainguinal bypass surgical site infection I'm going to go to in a little bit more detail. But we've also had length of stays for CEA and EVAR, as well as infrainguinal bypass, and CEA stroke death, CAS stroke death, and PVI hematoma. And we produce these reports on a quarterly, biannual basis. So let's look at the surgical site infection for infrainguinal bypass. This is the observed versus the expected incidence of infection for SSI in the VQI centers. And you can see this group of outliers in which the observed is much higher than the expected infection rate. So a working group was put together, which included Adam Beck, Jason Sharano, Jack Cronenwet, Mark Davies, Alec Farber, Karen Homa, Jeff Kalish, Megan Tracy, Miguel Trinidad, and Mark Wires. And they looked at 8,000 VQI procedures from 2003 to 2012. They found the variables associated with surgical site infection was BMI, skin prep, chlorhexidine with alcohol had a protective effect, tissue loss, graft recipient, transfusion greater than or equal to 3 units, and surgery time. Then they put together a report for each center. There's a center, the center's number, the number of procedures, the actual wound infection rate, and the expected rate. And then below, there is suggestions for improvement. In this particular center, it's the chlorhexidine skin prep. The transfusion greater than 3 units was also something to consider in procedure time, trying to make the procedures more expeditious to lower the infection rate. With this particular copy report, the penetration of the chlorhexidine alcohol prep is virtually 100% within VQI centers now, which was not the case prior to that report coming out. But we also know there's a variation in procedure volume, and that procedure volume variation is by location, as can be seen here from the Dartmouth Atlas for carotid endarterectomy. And every procedure, not only vascular but non-vascular procedures, has the same kind of distribution and variety. That may be due to local factors, but it can also be to the appropriateness of the procedures when they are used. The New York Times has taken an interest in this particular issue, and this is a very important article that came out in 2015, which demonstrated kind of the explosion in both arterial and venous procedures. and the fact that one cardiologist in Florida was actually paid $18 million in 1 year for the procedures that he was performing in this particular space. And they just asked the question, were all these procedures appropriate? It's a good question to ask. So Dr. Lawrence also asked that question, and in this society in 2015, his presidential address actually focused on the appropriateness and the appropriate application of procedures for vascular patients. And I quote, "We must benchmark appropriate indications for each vascular surgeon and provide a CAPI report, appropriateness report, similar to the COPI report to each VQI participant. This report can provide not only a benchmark regarding the appropriateness for the indications for treatment, but also opportunities for improvement, just like the COPI report." Appropriateness is the right procedure at the right place, the right provider, the right time, and the right cost. So how are we going to approach this? Well, first of all, the SVS provides, as you know, guidelines for multiple areas for the care of the vascular patient. We're going to use VQI data to assess guideline compliance, and that's already been done, subject of a presentation here at this meeting, and Dr. Kreis is also going to talk more in detail about this. The Quality Council is then going to apply the RAND UCLA appropriateness methodology to translate guidelines to appropriateness. We'll then use the VQI data to look at the appropriate application of that procedure once these appropriateness guidelines have been completed and provide the CAPI report. I can tell you that there is already significant payer interest in this area and payer interest in the VQI with regards to procedures. So this is what a CAPI report might look like. This is from Dr. Lawrence's presidential address. There's the center, the number of procedures the center did, the number of procedures the center really should have done based on the available data within the database, and then some measures on how the center might more appropriately apply procedures to patients with claudication. Should also say that one of the projects of the VQI going forward is to look at the new claudication guidelines and to see what the real-world compliance is for those guidelines in the VQI, and we'll be doing that this coming year, and that'll be in parallel with the appropriateness project that Dr. Kreis will discuss. So I think we can see we've kind of creating a quality circle with the VQI as kind of the foundation. We have the vascular literature, guidelines derived from the literature. There's vascular practice. We have the VQI to monitor that practice, both with the COPI and CAPI reports. This feeds back to vascular surgeons, cardiologists, radiologists, and other individuals in the vascular space. There is hopefully and should be modifications in practice, which will then be studied and contribute to the vascular literature, and the circle goes on and on and on. So I would just encourage all of you to join the VQI. It is a critical future tool for this society and for our group and for anybody taking care of a vascular patient. And really, without data, and now we can get that data through the Vascular Quality Initiative, you're just another person with an opinion. So if you really want to have evidence-based care, please join the VQI. Thank you.
Thank you very much, Fred. So to wrap up our speakers this morning, and we will have time for discussion, so please prepare any questions you may have. SVS leadership about 2 years ago started to look at our portfolio of quality products and realized that we had so many of them that we actually needed to create a quality council. And we enlisted Dr. Larry Kreis to in fact lead this council for us as the inaugural chair of that council. And he's going to talk to us about some of the efforts in that council, particularly as they relate to practice guidelines and appropriate use criteria. Larry?
Thank you, Dr. Hodgson, especially for the invitation to participate in the Crawford Issues Forum. It's a real honor to speak with you this morning. I disclose that I am a member of the Vascular Advisory Panel for AIM Specialty Health, which is a benefits management company. And my talk's going to be basically one to review clinical practice guidelines and then appropriate use criteria and contrast them with one another, hopefully to emphasize how they're complementary and not conflicting, and then make an argument for why the SVS should embark on developing a specific AUC. I want to acknowledge the assistance of Tom Forbes, who's the chair of the SVS doc, as well as the assistance of Nadine Caputo and Kristen Hitchcock in the office in preparing this presentation. The Institute of Medicine defines clinical practice guidelines as statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. Now, over the past few decades, clinical practice guidelines have proliferated. There are hundreds now in the literature developed to describe management of multiple different conditions and published by multiple different groups. And as a result, the Institute of Medicine said we're going to publish some criteria for trustworthiness because not all of these guidelines were of identical quality. So first and foremost, credible guidelines should be based on a systematic review of the literature, preferably prepared by a group of expert methodologists who are distinct from the multidisciplinary panel that will then use that literature base to develop the guidelines. The panel developing the guidelines must be rigorously transparent in acknowledgement of conflicts of interest to minimize bias. The panel should specifically consider important patient subgroups and their values and preferences. The guidelines should be framed as clear, unambiguous recommendations to either do something or not do something, and then provide ratings of the evidence quality and the strength of that recommendation. And then finally, as new information is developed, the guidelines should be updated. The process for assessing quality is standardized. One of the common ways of doing this is called the grade system, and evidence quality is then considered to be high if it's based on a meta-analysis of multiple quality randomized controlled trials that are done with good methodology and low risk of bias, hopefully delivered with a large effect size and consistent outcomes. And in the vascular space, an example of high quality evidence would be the small aneurysm studies that showed that repair of small aneurysms less than 5.5 centimeters did not confer an overall survival benefit. Low or very low quality evidence are observational studies that allow for bias to influence the results. Low quality studies may deliver small effect sizes, and some low quality studies may actually conflict with one another, yielding different outcomes. The strength of the recommendation is then graded either strong or weak. Strong recommendations are those where the benefits of the procedure clearly outweigh the risks for most or all patients. They're based on high quality evidence, and new information is unlikely to change the recommendation as it emerges. On the other hand, weak evidence or weak recommendations are for those procedures in which risks and benefits are more closely balanced. The procedure may not benefit every patient group. There may be some patient groups who are exceptions to the recommendation. Evidence quality may be low, and it may be that the recommendation will change as new information comes about. And it's in this area where the patient-specific preferences become most important. For instance, a patient with an asymptomatic carotid stenosis who fears surgery more than they fear a stroke may actually opt for medical therapy as opposed to a carotid intervention. And that would be an entirely appropriate decision in the space where the recommendation for intervention is potentially weak. Now, the SVS has been in the clinical guidelines business since 2006. There are 13 active guidelines that are listed on the website. The methodology by which the SVS develops clinical practice guidelines was published in 2011. And this review recognized that up to that point, early guidelines were actually based on pretty low quality evidence. And this was not an indictment of the guidelines as much as it's an indictment of the quality of the literature upon which those guidelines were able to be developed. The SVS methodology generally comports with the IOM trustworthiness criteria with two possible exceptions. Not every SVS panel that developed guidelines was multidisciplinary. And although the patient preference perspective is explicitly acknowledged in some of the guidelines, there has not been a panel member specifically tasked to represent the perspective of the patients in every set of guidelines. More recently, the evidence quality underlying the guidelines has improved. So in 2018, the clinical practice guidelines for AAA were released, containing 111 recommendations or statements, and now 26% of them were now based on high-quality evidence, a twofold improvement compared to the earlier situation. However, 59 strong recommendations were only supported only half of them were supported with high-quality evidence. So there's clearly work to do to improve the quality of the literature base on which vascular surgery recommendations and guidelines are based. Well, this is a lot of effort, and the question is, do guidelines actually change or improve clinical practice? And I'd have to say that the answer is complicated. The guidelines have been shown to improve practice in these areas if one adheres to the guidelines. Non-adherence to the guidelines was associated with lack of improvement. But that improvement is not always easy. Many of these guidelines documents have now become very lengthy and unwieldy and are frankly unworkable in daily clinical practice. And adherence to some of these guidelines may actually require a change in long-ingrained clinical practices that may not occur easily. And finally, some of the weaker guidelines may actually be wrong. And so if you're following the wrong guideline, you can hardly expect clinical care or outcomes to improve. Now, some of these shortcomings of the guidelines are the rationale for another type of practice recommendation called appropriate use criteria. And the rationale for this is articulated by the RAND Corporation, in which the evidence base for a particular decision in a particular clinical circumstance may be missing or inadequate to provide guidance for routine, everyday practice. The RAND Corporation goes on then to provide us with a definition for an appropriate procedure. It's one in which the expected health benefit exceeds the expected negative consequences by a sufficiently wide margin that the procedure is worth doing, exclusive of cost. Now, I know that cost was mentioned before, and that can be an area of discussion, but the original definition of appropriateness does not take cost into account. There's a validated process for developing appropriateness criteria, and one of the most common ones is the RAND UCLA method, which is actually a modified Delphi group decision-making model, once again based on a systematic literature review, which takes into account the quality of the evidence. A writing panel then takes that literature base and develops clinical scenarios which are designed to replicate the scenario or the circumstance that we often encounter in clinic. We have a given patient in front of us with a particular vascular problem, but that patient comes to us with a whole host of comorbidities that should influence decision making. These clinical scenarios, which may number into the hundreds, are then presented to a rating panel, which is multidisciplinary, generally expert in scope, and this rating panel then takes these clinical scenarios and gives each of those scenarios an appropriateness ranking. And the original RAND construct, the ranking was on a scale of 1 to 9, with procedures that were clearly inappropriate receiving grades of 1, all the way to the other end of grade 9, where a procedure was clearly appropriate. So a hypothetical example would be a patient who has a 58 millimeter AAA, which is not amenable to endovascular repair. And you can imagine that open repair on that patient could be anywhere from appropriate to inappropriate depending on the degree of heart failure that's present in that patient. So the same procedure for the same indication might be appropriate based on comorbidities that are present or the lack thereof. Now, other organizations have had some experience with this, and they've realized that some of the original RAND definitions are disadvantageous and communicate the wrong message. The American College of Cardiology has therefore changed their designation of inappropriate to rarely appropriate, and they've changed uncertain to maybe appropriate. So let's compare clinical practice guidelines and AUC one against the other. They're both based on a systematic literature review, both produced by experts. CPG, on the other hand, are clear, binary, do this, do not do this recommendations based on hopefully strong literature. AUC, on the other hand, are meant to fill in the gaps where the evidence base is not so strong and it may not directly apply to the specific clinical scenario that you're encountering in clinic. And therefore, it's not binary, but it's more a spectrum of appropriateness. However, CPG and AUC should never contradict one another. They should always be in alignment. So the argument for AUC, and more work, it takes time and effort to go through this process. But the argument for it is that it now becomes a tool to reduce variation in utilization in clinical practice. If there's a friendly point-of-care clinical decision support mechanism, you can actually access AUC at the point of care and decide if the procedure you're considering is appropriate or inappropriate. Payers want more concrete guidelines. And AUC may actually simplify pre-authorization for the more obvious situations. But most important, I think AUC that are developed by physicians using a validated process become strong authoritative statements in the marketplace. However, AUC are not a panacea. They may be construed as inflexible or restricting physician autonomy. They may actually be used by some payers inappropriately to deny care in particularly complex situations. And finally, AUC are not immune from a particular perspective based on one's specialty, and so AUC from different organizations may not necessarily agree with one another. However, we have to recognize that AUC, the train has already left the station. CMS has formally mandated the use of AUC for ordering advanced imaging studies such as CT, MRI, or nuclear medicine. Fortunately, CMS is going to recognize AUC that are developed by specialties or by provider-led entities as long as you follow a specified validated process. So we're not going to have to live with a top-down decision that CMS imposes on us. We can actually develop our own AUC as long as we do it according to a particular process. Now, CMS has only said that they're going to do this for advanced imaging so far, but there's really nothing to prevent them from extending AUC to other therapeutic procedures. And in 2015, a GAO report identified 3 vascular procedures as potentially of low value with wide variation in utilization and would potentially benefit from use of AUC to guide their utilization. And these are renal angioplasty, carotid endarterectomy for asymptomatic disease, and IVC filters. And regardless of what CMS does, there's nothing that prevents third-party payers from using AUC as a mechanism for pre-authorization. In fact, and now other societies have already delivered AUC recommendations for vascular procedures. Last year, the ACC led a multi-specialty effort, and they developed AUC for peripheral artery intervention. The SVS was invited to co-endorse this document, but decided not to. Only one of 13 panel members was a vascular surgeon, so we felt that the surgical perspective was diluted. We were concerned that there was a maybe appropriate designation for tibial artery intervention for claudication, something that conflicts with our guidelines. And it did not address concerns regarding unnecessary treatment in asymptomatic patients, something that many people in our organization are concerned about. So why should the SVS develop AUC? Well, I think other groups are already doing this. And if we're silent in this area, our viewpoint and the viewpoint that we take on behalf of our patients is not going to be heard. And I think AUC can be a tool to actually help us deliver better care in the clinic. So as you've heard today, we have an infrastructure in place, clinical practice guidelines, where we can make definite statements where evidence quality is high. We can now use AUC to fill in the gaps, and we have VQI, which can help us measure our compliance with CPG and AUC. Now I want to conclude with maybe a challenging example that strikes close to home for some people. The sac size threshold for a AAA recommended repair is based on strong 1A evidence, but the bar chart here represents the center-specific compliance with open AAA based on sac size, recognizing that in some centers, only 40% of open AAAs were done in an aneurysm that was greater than or equal to 5.5 centimeters, whereas other centers are always meeting the guideline. These centers to the left, some of them are performing open repairs on AAA, on sub-threshold AAA, more than 20% of the time, and some of them are doing so more than a third of the time. I submit to you that it's hard for these centers to defend this practice in the best interest of their patients. This represents an opportunity for improvement. VQI can communicate this information to individual centers confidentially, and then if SAC size is incorporated into AUC for AAA, VQI can monitor compliance. So the SVS board has authorized development of AUC in particular areas. This process will be closely tied to the updating of CPG. The first commissioned AUC will address intermittent claudication, but I invite the membership to participate in this process, especially on the rating panels, which may include up to 17 members. And we envision AUC coming out in carotid intervention, AAA management, and venous disease. And finally, again, please, if you're not participating in VQI, please enroll, because this is a way for you to benchmark the quality of your performance with your peers. And we need to make sure that our voice is heard to serve our patients' best interest. We have many tools to do that, and I thank you for the opportunity to speak with you today.
Thank you very much, Larry. That was great. I must admit, when I was first exposed to this concept, I couldn't really quite figure out the difference between clinical practice guidelines and AUCs, but clearly they're complementary but serve important individual roles. There are microphones in either of the two side aisles if anybody has any questions. I thought that I might start by amplifying something that Dr. Seed mentioned to us in her presentation, and that is to work with your professional society, because the backstory behind how the S first became involved with Dr. Seed is some regulations that were passed in the state of Pennsylvania that were problematic for some of our members. They contacted the SVS, and the SVS, President Macaroon, Ken Slaw, and past President Ron Ferriman, both of whom practice in Pennsylvania, went and met with her to discuss those. So those are important things going there. Just quickly, Arlene, I wondered if you could just tell us, what is it that caught your attention about these procedures?
Well, there was a CMS guideline, but when we looked at our internal data, there weren't a lot of deaths in ASCs, hardly any, but the ones that were in the vascular arena, and the top one for the entire state was a vascular center. So that's what started. We had the external request, and then we had internal data telling us to be cautious.
Yeah. Dr. Veith.
Yeah, it's an excellent session. I have a couple of comments I'd like to hear responses to. The first is to Larry. You highlighted the excellence or the importance of guidelines. And Peter Bell and I wrote an article showing that guidelines can be extraordinarily flawed because of the bias of the people that write them. And the example of that is there are, I think, 32 carotid guidelines around the world. And they're all based on the same randomized trials, and they all come up with dramatically different conclusions about asymptomatic carotid disease, etc. And many of their conclusions are wrong. So I just want to highlight that not only can randomized trials be flawed, but more importantly, guidelines can be extraordinarily flawed. That's my first comment. Larry, would you respond to that?
Well, I'd say if the guidelines comport with the guidelines for the criteria for trustworthiness, then whatever bias was existed on the part of the panel members should be evident. And if that's not true, then that's a problem. So it's hard for me to address all 32 guidelines that produce conflicting information, but it's also possible that some of the guidelines, even though they're based on randomized controlled trials, if those trials don't deliver large effect sizes in the same direction, that's still not high quality evidence.
Okay. And secondly, to Tony, you mentioned that the ACS and the SVS are developing these criteria for centers. You're aware that I think it's the American College of Cardiology is doing the same thing, and I just wonder how you can reconcile those. Recently, there was a big article in JACS where the ACC was saying that we ought to have centers of excellence, presumably with their leadership in peripheral vascular disease, pulmonary emboli, and acute aortic syndromes. And you have the two groups working. How are you going to get them to do the same thing and reconcile it? And who should lead these centers?
Well, I think I can say that we invited all specialty societies in that space, and we had representatives from SIR coming to 2 meetings, and then representative from ACC to come to 1 meeting with us, along with SIR and us. And then they decided not to come anymore. So our decision is that this is something good we're doing, and we feel if we come up with a good program at the end, that's applicable to everyone in that space. But if the program is good, they'll come along.
But interestingly, the article in JACS had about 12 authors. Not one was a vascular surgeon.
No, I understand. I'm just stating exactly what happened. We were very open, invited all these specialties. Michelle Macaroon, who's sitting here, our president, actually did the yeoman work to bring him on board, and they came, and then they decided not to after that. We have a good program, I believe, and if it becomes successful, people will come. That's what happened with VQI. You have representations from multiple societies, or at least multiple specialties. I cannot say societies also, although I believe SIR is a sponsor of VQI as well. Isn't that true, Fred?
What's that?
SIR.
Yes, they are part.
I think Dr. Macaroon has something to add to that.
Just a minor update. I think one of the reasons that the partners in the vascular space pulled out was not necessarily a total disagreement with the purpose or with the process. I think they had some issues with the priorities that were being set. They are more interested to see the outpatient piece of the puzzle being first and pushed forward, and we're having conversations with all of the partners again, and we do have some optimism that actually that may be reversed, and we are all going to come back to the same room to talk about working all together.
Thank you.
Let's go to this microphone.
Mike Conti.
Hi, I just wanted to first emphasize and congratulate the SVS leadership for this entire work product that's ongoing. There's really nothing, I think, that's more important to demonstrate the SVS commitment to our patients than what you guys are doing here. And the folks up on the stage have done tremendous work that's really important to the future of our specialty. I'd say one comment and one question. My comment about our reliance on VQI is critical, but I think we can't be too complacent about VQI because really the quality of the care we provide can't be measured in just the 30-day outcome. And if we don't get better about looking at the long-term value of what we do for vascular health, we're going to be limiting what we're really able to talk about in terms of quality. So while we need more involvement in VQI, we need better compliance and actually I think even better long-term follow-up data, particularly because we treat mostly chronic diseases. And if we can't show the benefit or the quality on improving long-term vascular health, it'll be a very limited lens that we're using. So I wonder if Fred might address that. And then the other question I have is for Larry, which is, you mentioned the importance about patient stakeholder input, which is absolutely critical in some of these value decisions where it's very nuanced. You mentioned it about guidelines, but you didn't bring it into the AUC part of the conversation. I haven't seen much of that in the AUC world, but my question is, what are the standards for doing this? I mean, there's a broad, how do you get enough patient stakeholder input to really be generalizable and broadly reflecting of the public that has the problems and the diseases we're treating?
So thanks, Mike, for that question. The VQI is aware of the importance of follow-up. So we have an ongoing task force to improve overall follow-up, and I'm happy to say that we have moved the needle a little bit, about 5 percentage points to as far as follow-up is concerned at 1 year. We've also instituted 30-day follow-up in a number of the modules, such as the carotid and the infrarenal bypass. So we are aware of that. The other issue that we try to help with that is indexing to the Social Security Death Index, and also claims matching with Medicare claims. And there's a robust process and methodology to do that, to provide more granularity for long-term outcomes using the VQI. And to my knowledge, and Larry may know if it's different, to my knowledge, none of the other databases have the robust connection that we've used with the Social Security Index as well as with the Medicare claims. So we hear you, but there's also methodologies that are addressing this to provide more robust data.
With regard to the patient perspective, because clinical practice guidelines deliver binary, do this, do not do this sort of recommendations, the patient perspective needs to be considered at the guideline development level. In the appropriateness process, the patient's perspective is actually addressed by the provider in clinic. And when you're dealing with a situation in which the mix of comorbidities and the procedure you're considering doing falls in the 4 to 6 range may be appropriate, the difference is whether you do it or not do it may be the patient's perspective and the relative value that they place on different outcomes or avoiding certain types of complications or adverse consequences. So the patient perspective is kind of implicit in the appropriateness process, but it's moved from the development stage to the clinic, especially when you're dealing with procedures that may or may not be appropriate.
Past President Glavitsky.
Excellent session and a very important topic. A question to Dr. Kreis. In previous guidelines, we used best practice as a category for those procedures that we do that don't have a lot of evidence, or where practically the decision or recommendation is consensus-based and not evidence-based. So should we get rid of that category, or that should belong to an appropriateness criteria? What do you think, Larry?
I think there's a lot of wisdom in that decision. I think there's discussion about that, but I don't know if a final decision has been made. I know that there has been external criticism of the AAA guidelines in particular because so many of their strong recommendations were based on weak or what was graded as weak evidence. And so it may be that a better policy would be to focus on fewer guidelines for which strong recommendations can be made backed up by strong, high-quality evidence, and then move all of the other things into an appropriateness sort of paradigm where you now have a lot more flexibility to make a different decision based on patient factors.
Yes.
Deepak Nair, Sarasota, Florida. Dr. Seed, you in Pennsylvania need to be congratulated for developing office-based surgery guidelines that you have. They're one of the most accurate and robust in the country. There's one part of it that we've had issues with in Florida with the same sort of evolution that happened with you due to bad cases. That's confusing for our members. Vascular surgeons in Pennsylvania, other interventionalists, that says you're not allowed to do procedures on direct major arteries. So it's a little nebulous. We had the same language in Florida, and then we ended up modifying it and clarifying it, because the word direct you're directly involving an artery if you're doing an endovascular procedure, as well as major artery. Most arteries are major. So if you can clarify that and look at the other states and see what they did, I think that would be helpful for our membership.
Thank you for that feedback. I can discuss this with you outside. I want to take a look at we have a regulation that doesn't allow procedures on any procedures that there's a risk of bleeding or on direct artery. That's a regulation, and as we talked about it, it is the way it's been interpreted. So that's the regulation. What we wrote was a guideline. The guideline is open to more, so we can talk afterwards. Thank you.
So, past President Peter Lawrence has a question, and I want to give a shout out to him. He's the gentleman that birthed this concept in the SVS with your presidential address. Peter, I'll be anxious to hear what you have to say.
Great. Well, just first of all, it's great to hear the progress and the fact that we're continuing to address this since my opportunity to talk about this 4 or 5 years ago in the presidential address, and now considering not only practice guidelines but centers and appropriate use. My question has to do with I sat on MedCAC for a 6-year period where there was one on arterial and one on venous. And for some of you know, the MedCAC is an advisory committee that tells Medicare whether or not we should reimburse or pay for certain types of procedures. And one of the very discouraging parts of that for me was that when I asked about issues of training and whether or not people should be reimbursed that had no training in arterial or venous disease, I was told that this was a decision made by the Congress that any physician who has an MD has the right to do these procedures. So we can develop tremendous programs, centers, guidelines, appropriate use, but if there are physicians who have had zero training in vascular disease who get the same reimbursement for doing the same procedures, it's unlikely to raise the level of care. So I'd be interested in your comments about whether or not, why you think it is that our government and the United States has decided to not recognize specialty training of physicians and include that as one of the criteria for doing these procedures, working in the centers, and participating and getting reimbursed.
That was a softball thrown to you there.
Actually, in our guidelines, we do. We actually have requirements for training and require that those who perform those in our ambulatory surgical facilities have a certification from an accredited body.
I think you would find in venous disease particularly that a significant number of the people who do ablation procedures, many of them have had no training. In fact, when I checked in near UCLA and called up a couple of centers who have billboards on the 405 and asked what the training was and said, is there somebody board certified if I were to have my veins treated? And then they assured me that it was, and I said, what's the specialty? And one was a bariatric general surgeon, one was a neurologist, and the third was an emergency room physician. And if you look at the Green Book on what the training criteria are, there's nothing related to venous disease in any of those specialties. So I find it hard to believe that people actually have training who are getting paid and do these procedures.
Last question of the session.
Thank you. Matthew Mell from UC Davis. This is a great session, and this is for either Larry and or Fred. I think the concept of AUC is great. I think the flip side of that is appropriate non-use. And I think, part of our challenge and challenges in general is that there's really no way for us to monitor, measure, and get credit for when we actually don't offer a procedure. And, I would just wonder if on the VQI, if there's any interest in having disease-based collection of data rather than procedural-based collection of data, because I think that moving forward, it may be a really powerful message as our specialty to say, look, we treat appropriately and we actually don't treat appropriately as well.
So, yes, I think the medicine registry that is slated for carotid lower extremity revascularization and aorta, that medicine registry will answer. Those will all be patients that are not operated on, that are simply treated medically with data and variables within that. And, going down the line, being able to compare patients that were medically treated for a certain, let's say, size aneurysm versus those that may have had a procedure in the EVAR module. There's all kinds of opportunities to look at that and actually to look at the appropriateness as well as the ability of non-interventional measures to take care of vascular patients. So that is coming, Matt.
All right, well, this has been a great session. One closing comment I would make would be one thing I learned today, which really puts fear in me, is what Larry said, and that is that any third-party payer can put together their own AUCs. This is really why we have to do it. We have to be out front on this kind of thing because, good Lord, if you had to deal with different AUCs from all your different payers, what a nightmare this would become. Thank you all for attending, and we'll see you at the next Crawford Issues Forum.